Basically, a 16-year-old male presented with complaints of pain and swelling in the left knee for the past 2 days. He had a history of slip and fall from bike, underwent initial treatment with a local general practitioner. On clinical findings, there was an extension deficit of 5 degrees and latchment was positive. And the anti-dryer I could not elicit because of the pain. This were his X-ray findings. So my next question to the panel is, what are your treatment options? Anybody for a conservative management among the panelists? What do you want to do next?
It's a displaced fragment of the ACL avulsion, so I think it needs surgical treatment, so there's no role for conservative treatment.
Okay. So what is the further management that you're going to see?
Now, once the swelling has settled down, I think he'll be a candidate for an arthroscopic ACL avulsion repair.
Okay. Any imaging that you would like to do?
Yeah, imaging to rule out other ligament injuries, probably we may have to get an MRI done, and to assess the size of the fragment, a CT would be better.
Okay. Among the panelists, what is the investigation of your choice? Any further evaluation that you're going to do? How many of you want to do a CT alone?
CT scan out first.
Alone, okay. How many of you want to do an MRI alone?
Ideally, you do both, I think.
Just got an MRI done and it shows a displaced ACL avulsion fragment from the tibia. So the next question, if it is operative fixation, how many of you are going to do an open fixation? So Dr. Subbareddy, are you going to do it open or arthroscopic? Arthroscopic. Okay. Dr. Magnus?
Yeah, arthroscopic.
Dr. Ashok Selvaraj?
Yeah.
I'll prefer an arthroscopic procedure. Okay. So only thing I want to know is in the MRI is the lateral meniscus also is avulsed along with the ACL because the fragment looks bigger. So that's one of the reasons I need an MRI to see if the antihorn of the lateral meniscus or the medial meniscus is also involved with that, so that we can plan the procedure. So in those cases, CT alone won't be enough. So we need an MRI for that as well.
Exactly. Thank you. Dr. Vijay?
Yeah, I'd like to fix it arthroscopically, reduce it and fix it arthroscopically.
Fine. So what would be your technique of fixation? Screw, how many of you guys would do it with a screw?
No, the size of the fragment doesn't look too big, and also biomechanically the suture technique would be better. So I would probably prefer...
Do you guys, any of you guys do with a screw? Nobody does. Okay. So how many of you do it with just sutures alone? That is suture bridge technique.
Yes, suture.
Okay, fine. And suture button? You do with a suture button? No. Okay. Again, okay, nobody does with a screw, so this question is impertinent, I think. Among the audience, how many of you do with a screw? Nobody does with a screw? So, if it is with suture bridge fixation, how many tunnels do you want to use, Dr. Shashi Kanth? 1, 2, 3, or 4?
My preference would be 2 tunnels, one anterior and posterior.
Anterior and posterior. Okay.
On the footprint.
On the footprint. So how do you access the posterior aspect of the fragment? You want to lift the entire fragment up and then put the tunnel?
Before we put it back into the crater, obviously the meniscofemoral ligament has to be removed, because that is the one which usually prevents the reduction.
Okay.
And then debride the crater and then drill the posterior tunnel and the anterior tunnel and fix it back.
Okay. Dr. Vijay, how many tunnels will you use?
I use 2 tunnels.
Okay.
And then fix it, bring it back and fix it down. Yeah.
Okay. Dr. Ashok?
So I use 2 tunnels, anteromedial and anterolateral. The main issue with the ACL avulsion is they heal, but they heal with the anterior prominence, which will cause extension deficit later. So it is very important to get the anterior reduction. So it's very important. So you make sure you get the anterior. So you may get some lift off posterior, doesn't matter, but you should not get any anterior lift off so that the extension is full.
Dr. Magnus, how many tunnels and position of your tunnels?
1 or 2, depends a little bit, but just put the fragment down, then I will put the patient in a locked brace with full weight bearing, which will help, right? So
how many of you, Dr. Subbareddy, sorry.
Mostly 1 or 2 tunnels, depending on the fragment size.
And do you over reduce the fragment anteriorly?
No, sir. I'll
You don't
just
over
make it
reduce
flush to
exactly at
bone.
the side.
Yes, sir.
Now, suture button, how many of you use a suture button to fix like a mini tightrope? You said you use it, right? Dr. Subbareddy, you said you use a mini fragment suture button, right?
Usually I use for tying it the tibial ends. I don't use the
You don't use it? Okay. I think my co-panelist, co-chairman does it. So, can you tell a tip how to avoid impingement in that?
I think this is a very fast and simple technique, but it relies on your tunnel being in the exact position. So seeing your reduction of your fragments. So firstly, this is good for very large fragments, not for small fragments. So my indications are larger fragments. The direction of pull of your tightrope, mini tightrope, has to be in the direction which the fragment needs to come in to get reduced. So if it's coming in from the, let's say, the lateral to the medial side, you need to have your trajectory in that direction so as to make it sit. One has to be very careful that while you over tension it, and while you tension it, you don't over tension it, because that itself can cause the fragment to shatter.
Thank you. Again, tibial fixation, Dr. Shashi Kanth, what is your fixation mode? Whether you use a button or you don't use any buttons, if you just tie it over the bone.
Because I am using 2 tunnels, I'll just tie it, use as a bone bridge. No other fixation.
The other panelists, anything do differently?
I use a button.
Use a button, okay. Do you have any challenges while tying the button? Because if you use the Arthrix button, the sutures come off. Because the bone bridge is there and you try to tie it, it kind of slips off from that. So, anything else? Because the tunnels are placed separately, so to tie that, it's not that easy to bring the button there.
Yeah, but while making the tunnels, we take care, they're not too far apart when you put the button. That's it.
Ashok, you do button?
No buttons.
No button.
No buttons.
No button. Dr. Magnus, button, suture anchor, what do you use for fixation on the tibia?
Anyway, it depends what I'm having on my shelf, really. So, yeah. I don't have a straight answer to that question, really. Depends.
Depends, okay. So, any specific indications when you use a suture anchor to fix it?
I could use a suture anchor, yes.
Okay, fine. So, rehab, anything, how many of you do non-weight bearing rehab for this patient?
So 2 weeks non-weight bearing.
Okay.
No knee RM for first 2 weeks.
Okay.
Important to keep the knee in maximum extension.
Okay.
So if required, had some pad in the distal aspect of the brace as well. So keep the knee, if in hyperextension knee, so keep some pad in the distal aspect of the knee brace, so keep it extended.
Okay.
So those are the key factors. After 2 weeks, you can get the range of motion 90 by 6.
Okay.
Partial weight bearing, full weight bearing by 6 weeks.
Okay. And same with all of the panelists, you don't put weight for 2 weeks, or somebody starts weight bearing immediately?
Full weight bearing
Immediately.
immediately for me.
And knee ROM, when do you start the knee ROM? Knee range of movement?
Yeah. Unloaded, they will start after 2 weeks.
After 2 weeks, okay. And do you find any difference in the return to sports with these patients?
Faster.
They do faster, okay. Yeah, and the whole goal of this is you should fix these fragments. Importantly, you don't leave them for lateral fixation because, like what Dr. Ashok said, the anterior horn of the lateral meniscus is attached to the fragment. So, on a later date, if you want to remove the fragment, you will detach the lateral meniscus anterior horn inadvertently, and that way is a disaster. So, the patients have persistent pain. So, you have to fix these fragments.